Hi, it's Dr. Centeno, and welcome to another episode of You've Got the Power. This is our 1 hour show, approximately, that I try to do twice a week on Mondays and Fridays, and kind of experimenting with a new format here. We're going to go through a specific lecture and specific topic. And I've always kind of done a specific topic and then opened it up to questions, where those questions are about what it is we're talking about or anything else that's on your mind. It doesn't have to be about this topic. But what's new is focusing on the use of some slides and a little bit more of a formal presentation. And I think that might help people learn a little better. Previously, we were back and forth, kind of two talking heads. Then I was kind of experimenting with just me talking about a topic, but so far this seems to be working pretty well. Let me know if you think this kind of presentation is working well. So today we're going to talk about what is thoracic outlet syndrome and how that's connected to neck instability. Now, thoracic outlet syndrome is a big topic, doesn't have to be connected to neck instability, but today we're going to kind of connect those specific dots. At first, we'll talk about thoracic outlet more generally. What is that? Where can it occur? And then we'll get into how that could be connected to an unstable neck. Again, we're going to spend about an hour today, about 10 minutes on this topic, and then I'll get into Q&A. The Q&A can be about this topic, but doesn't have to be. It can be really about anything that you want to learn about. And I'll try, once we get into the Q&A section, to use diagrams and other things to try to show people what's going on. So let's start this one. What is thoracic outlet syndrome? Is it connected with neck instability? So the thoracic outlet is basically three different places. It's not just one. And I know my cursor is large on my screen, but small on yours. So I'll move it around a lot, see if you can see it. So this site mark number 1 is where the brachial plexus, or the nerves that come out of the neck, go through the scalene muscles. And then the site mark number 2 here is when those nerves go between the clavicle or collarbone on the top and the ribs on the bottom. And then finally, the site mark number 3 is where the nerves go underneath the pectoralis minor muscle. So those 3 spots are where these brachial plexus nerves can get irritated. And all 3 are kind of lumped into that category of thoracic outlet syndrome. Now, the scalene muscles at number 1, that situation is the floor of the thoracic outlet is the rib, and the walls are made up by the scalene muscles. Now, the scalene muscles help to hold the neck up, as I'll show you a little bit later. And so problems here tend to occur when the scalene muscles get tight, and that puts pressure on these nerves called the brachial plexus. That second site we were talking about is where the floor of the thoracic outlet is the ribs, and the roof is the collarbone. And this tends to be more in situations when there's a high rib on that side. So more in situations where there might be damage to the fascial covering of the ribs. So when someone takes a deep breath, that rib comes up, and then that gets trapped. The nerves get trapped between the rib and the collarbone. And then finally, that number 3 site is the pec minor. And that's when the nerves dive underneath the pec minor. The pec minor attaches to the coracoid process here. The pec major, the one we see is the pectoralis, like when someone's working on their pecs. That's the pec major here. But underneath that is the pec minor, and that's where those nerves go. So this kind of thoracic outlet syndrome is related to the tightness in that pec minor, or the tightness in those pecs, or the tightness in the chest wall. The scalene muscles, and now we're going to focus a little bit more on the instability part, because this is where those scalene muscles kind of come in. Those scalene muscles, this is sort of an actual picture shown here, And you can see you've got a posterior scalene and a middle scalene and an anterior scalene. And what's interesting is they attach to the neck, and they start here at the ribs. So if you think about what do these scalene muscles do? Why are they there? Well, they're really there in the same way as guy wires, or what we call in sailing shrouds, are there to hold up the mast, right? You've got this long mast. You want to put a powerful sail on it. You don't want the whole thing to fall down. So you've got to put these guy wires here in tight to keep the mast up straight. And in the same way, these scalene muscles act like guy wires for the neck. And if that neck or those bones get unstable, you've got to tighten down the guy wires. Just like if your mast is moving when you're sailing, you better tighten down those shrouds, or your mast is going to go like that. So in neck instability, damaged ligaments cause excessive motion between the vertebra, and that can lead to the scalene muscles getting tight to compensate. Now, that could be this kind of stair-step instability we see here, which is common in an EDS patient, or upper cervical instability, or other types of traumatic instability in other parts of the spine. But again, the scalene muscles are jumping in to try to stabilize things. And what happens then is, as the scalene muscles get tight, the nerves, as they go through this area, or the brachial plexus, gets pinched. So here we've got this direct correlation between what's happening in the neck and what's causing potentially numbness, tingling, or weakness down the arm. Now, the nerves in the neck, or the spinal nerves, could also be getting pinched there due to a disc bulge or instability, but they don't have to be. They can also get pinched up in here, which is the thoracic outlet, just because those scalene muscles are tight because the neck is unstable, causing these brachial plexus nerves to get irritated, numbness, tingling in the hand, sometimes weakness. So realize that if you've got neck instability, those neck nerves don't have to be getting pinched there to cause numbness in the hand. That tightness in the scalenes can do it through the thoracic outlet. So how can you help thoracic outlet syndrome? Well, one is obviously physical therapy. You can stabilize the neck. You can stretch open this area to try to see if that provides better room for the nerves. If that doesn't work, we can do direct treatment of the nerves and scalenes with ultrasound-guided platelet lysate hydrodissection. So that's where we can put some growth factors from platelets under ultrasound imaging very precisely around those nerves that could be scarred down and break all that open. Obviously, we can tighten the damaged neck ligaments through injection, or obviously you can fuse the neck. Those are the different options for treatment on thoracic outlet syndrome. So that's what I have for you today. I'd like to go to some questions now, and then hopefully we'll use some diagrams as we go. So let's start here. I'll start with Robin. Hi, Dr. Centeno. My sister had a synovial cyst at L4-5. You have an informative blog and video on the exact location cyst. My sister has had a cortisone shot recently with some improvement. Do you recommend Regenexx Rhode Island or New York for a possible consult for her next steps? Can Regenexx providers drain the cyst like you did in your video and blog? Yeah, so Robin, that's a good question. And so what Robin's talking about is, let's actually pull up some pictures here so we can see what that looks like. So the facet joints are the joints that happen in your back, and they can develop cysts just like other joints can. The difference in the facet joints is that sometimes the cysts aren't in the best locations. So I'm going to go ahead and try to share this screen with you here. Okay, so you can see here that this is a synovial cyst, a very, very big one. So these are the facet joints here in a low back MRI. Those are left and right. And this arrow points to this cyst, which is basically an expansion out of the little joint. And those those cysts can put pressure on the nerves, which are the dots in the middle here. Now you got a couple options with a synovial cyst. One is you can try to reduce swelling in the joint. So you can do cortisone, not real healthy for the joint. It's probably going to cause more problems down the road. Or you can do PRP in the joint. And if that doesn't get rid of the cyst, then you can try to burst the cyst by injecting a lot of fluid in there, which is what I was doing that Robin was talking about. And or you can operate on the cyst. As far as draining a cyst like that, it's kind of a very specific technique. So I don't know if a specific Regenix center can do it. It's one that I kind of invented, if you will, on getting a needle back here directly into the cyst and then another needle into the joint. So I'd have to do more research on whether a specific clinic would want to do that or not. But what Rob was talking about was a video where I was putting fluid into this part of the cyst and it was coming out the other needle or vice versa and establishing a connection on both sides of the cyst. Centeno Schultz Clinic submitted advanced by Harry Winston. I was diagnosed with Thoracic Outlet syndrome 2 years before my neck issues, which we think is CCI, but need a DMX. Could TOS have resulted from my weightlifting? Yeah, good question. The answer is yes. TOS can happen from weightlifting. You can get overdeveloped in the chest. And a lot of times that would be the pec minor that needs to be released. So that number 3 one that I showed you there. Now, more commonly, if you have CCI, it's probably tight scalenes because that's a common one in CCI patients. But what certainly could have happened is that you had neck instability. It just wasn't showing up clinically. The scalenes were jumping in to try to tighten that down. And then eventually the neck issues kind of became an issue all unto themselves. Adina, is PICL or PRP better for horizontal instability than for vertical instability? Yeah, so it just depends on what you mean by vertical instability. So I'd need to know more. If you're talking about a Bayesian-Denz interval going up in flexion, then that's a PICL thing. As far as PRP for, I think you're talking about posterior injections of the supraspinous and interspinous ligaments, which is really not going to impact the Bayesian-Denz interval. Let's see if we can pull that up. I think you're talking about a dynamic BDI. So let's see what I can pull up here. Okay. So Bayesian-Denz interval, I'm not quite sure if you can see that. Might be better. This one might be better for you. So that's going to be this line here. And so we're talking about the distance between the front of the skull up in here and the dens. Now, if you're talking about vertical instability, that would be that this line or this measurement here called the BDI gets bigger with motion. And the only way that's going to be treated is with the PICL procedure. There's no posterior injection that's going to move the needle on that. So I believe that's what you're talking about, is a dynamic BDI where it's getting bigger with movement. But if you're talking about something else, please let me know. Nicole, hi, Dr. Centeno. I have CCI and TOS. I had PICL 215 is okay to lift weights. Always had increased pain, but I also feel my loss of muscle has made my symptoms worse. Is weightlifting safe with CCI and TOS? Well, so if you were lifting weights before and it wasn't really destroying you, then I think it's reasonable to continue to lift weights as you were doing before. So I wouldn't be too concerned about that. I wouldn't want you to lift heavy weights, but if you're doing light weightlifting before and that seems to make you feel better, that's fine. At this juncture, you're kind of 3 months out, so that would be fine. Phil had cervical PRP, C0, 1, 2, 3, 4 at algo cells, first 2 weeks of improvement, honeymoon period, symptoms returned to baseline at week 3. What is the protocol for determining if when more PRP required? Phil, I would say you'd want to give that about 4 to 6 weeks. If at the end of 4 to 6 weeks you don't feel any additional benefit from the PRP in those joints and you have CCI, then that would be more of that PICL procedure in Colorado. So that would be where you'd go. Now, if you do get some improvement, then you could certainly repeat PRP on those joints. But if you get no improvement, we're probably looking at more of that PICL procedure. Adrienne, does an untreated disc tear increase risk of further injury at that site in the future? Adrienne, that's an interesting one. Let's look up a high intensity zone. Oh, there's one of ours. So basically, you're talking about a little white spot in the back part of the disc. And a white spot in the back of the disc is called a high intensity zone. There's another picture of it. And that indicates a disc tear. Now, it doesn't mean that disc tear needs to be treated, because an awful lot of people have zero pain and zero problems that are walking around with torn discs. So we've got to be very, very careful about that. Here's a bunch of different torn discs in this one here. And it's these white spots in the back of the disc on the MRI. So if we knew that disc tear was causing you pain, then it should be treated. If it's just an incidental disc tear, like lots of people have that are walking around that are totally normal and will probably never have any pain, then it doesn't need to be treated. And again, that's an important thing to realize, that what's on your MRI versus what's actually causing you pain are commonly two different things. So be very, very careful when you're focusing on all these little things on your MRI, because if they're not causing your pain and they are really common in the normal population, you shouldn't be worried about them. Phil, regarding thoracic outlet syndrome, are there any functional or logic tests that can differentiate whether it's cervical induced or not? Yeah, Phil, there are a couple. Let's see what we can find online. Okay, thoracic outlet syndrome, and then we're going to do tests to see, well, we'll do physical exam. The answer is yes, there's a bunch. I'm just wondering if I can find anything I can show you. The problem with most of these tests is they're designed to look for vascular thoracic outlets. So this one is one that looks at the pec minor. So you bring the person's arm back like this and see if their hand goes numb. And that's stretching it, those nerves underneath the pec minor. And there are other tests that you can do. I'm trying to see if we can find others that aren't very, very specific to vascular thoracic outlet, because vascular thoracic outlet is almost a different animal. So another one is this. It doesn't really show you much here, but you can try to trap the nerves between the rib and the clavicle for that number 2 spot. So you can press down here and then ask the person to take a deep breath in and hold it. And if when they take a deep breath in and that brings the rib up to push on the nerves, then that can cause numbness down the hand. And then finally, with regard to scalenes, you can actually put pressure right here to see if that causes numbness down the hand in the scalene triangle. So there's a bunch of different tests that you can do to try to see if the issue is coming from the thoracic outlet. Centeno Schultz Clinic, submitted advance by Sherry Scopp. How long after the occurrence of CCI diagnosed by DMX is it safe to wait before getting treatment? Is there any chance it'll heal on its own? Sherry, it's the same old adage, right? If you have an acute injury that's ligament or tendon based, it's generally going to heal in the order of 6 to 12 weeks. Now, sometimes quicker, sometimes less. So if you've got an acute injury that you think has caused craniocervical instability, you're going to give it at least that long before you do anything to it. Now, if you get to that 3-month mark and you still have the issue, then you're in that situation where it's much, much less likely to heal on its own. And it really depends on how you're doing physically. If you're doing well physically, then I would say not a problem. You can wait and see if the symptoms decline over time. If you're doing poorly, then I think it behooves you to get treated sooner rather than later, because I've certainly seen people that have waited years and years, because of their diagnosis hasn't been done. It takes years and years to get to a diagnosis. And I think they're a little harder to treat than those people who are who get diagnosed and treated earlier. Adrienne, does untreated lumbar disc tear increase risk of further injury? Yeah, I think I've answered that one. Adina, according to most neurosurgeons, as long as the spinal cord brainstem is not compressed, the translation of the video in dynamic imaging does not matter. Can you please advise how else exactly the nervous system is influenced other than by direct compression? Yeah, I would agree with what you've heard from the neurosurgeons, meaning that as far as the BAI is concerned, that's not a measurement we would use to define instability. We use different types of measurements. We would use a C1, C2 overhang on DMX. We would use a grab Oaks more than 9 or a dynamic grab Oaks that changes in a flexion extension MRI. So again, you have to realize, though, that now let's go down a layer of the onion deeper, in that most neurosurgeons don't specialize in this area of CCI. So frankly, unless you've got a hangman's fracture or you've got that DENS severely compressing the brainstem, they're not going to recommend any type of surgery, whereas you may need surgery and not have those things. So you have to be a little careful there. And then how the central nervous system is influenced, we're talking about usually a static image. So in that static image, regrettably, we see what we see. Instability is a movement-based concept. So if on the static image something isn't compressed, it doesn't mean a lot because it may get compressed as the patient moves. And then you go down a level deeper, which goes into the status of the nerve. What else could be impacting the nerve, or what else is the instability aggravating? So regrettably, the simplest concept is, well, your MRI looks like there's nothing being compressed, you don't need surgery. But a more complex understanding would say, well, we need to see whether or not when you move, things are getting irritated. And then another level down would be, what is that irritation causing? Meaning, is it causing muscle spasm? Is it causing other nerves to get irritated, et cetera, et cetera? So that's just 3 levels, and there's about a half dozen down there. Burke, what is the success rate for patients with HEDS and CCI? I don't know the success rate of what we're asking here, but if you're talking about PICL, I think it's harder to treat EDS patients, but I think they ultimately end up in the same place as non-EDS patients who have CCI. When it comes to fusion, just my observation has been that fusion is not a great fit for many CCI patients because they tend to get so easily overloaded above and below the fusion. So I'm not quite sure what you're asking about there. Regenix, submitted advanced by Jeremiah Lee. How do you tell if the issue is thoracic outlet syndrome or rotator cuff tear? I saw 2 docs about the same issue and got these 2 different diagnoses, or can you actually have them both? Yeah, Jeremiah, you can actually have them both. So it could be both thoracic outlet and a rotator cuff tear. And they're 2 different things, right? A rotator cuff physical exam would be something like this, where you have what's called an empty can test. So you point the thumb down like that, and you go about 30 degrees forward, and that hurts a lot. That's for instance, a rotator cuff test. But if I put pressure here on the scalenes and your arms go numb, that's a thoracic outlet test. So the tests are very different, and there should be a good way to differentiate between them or to see if you have both. Adina, should PRP, PICL be combined with an atlas orthogonal in order to be effective? Otherwise, it's possible that ligaments are stabilized in the wrong position. Yeah, Dina, we generally don't see the ligaments stabilized in the wrong position. Realize that things get out of position because the ligaments are loose. So if we tighten the ligaments, we're good. Having said that, we see a lot of patients that get great benefit from AO, chiropractic, or atlas orthogonal. So if you've got an AO provider who can get you in and it feels great temporarily, we definitely tell those patients to make sure that they continue to see their AO provider as we go forward. Jalal, are your ligaments more susceptible to injury in the weeks after a PICL? Shouldn't be, Jalal. There's really nothing that we're doing that would make them more susceptible to injury during that time. What can happen, though, is you can feel pretty good for that first week to 2 weeks because things are swollen, and then at around 10 days to 2 to 3 weeks, the acute inflammation goes down and the ligaments become loose again. And some people mistake that loss of that protective inflammation as I re-injured myself. So that one's pretty common. Stacy, are you able to see on diagnostic imaging the difference between the damage and the increase in damage caused by trauma versus natural degeneration? Wow, that's a super duper duper complex question, Stacy, that would require looking at a specific case because it's can be very difficult to tell the difference. Sometimes having pictures before and after event can make a big difference because we can say, aha, that wasn't there before. But it really is a case-by-case scenario that's got to be looked at and teased apart. Ali, if one has the sternocleidomastoid muscle, sternocleidomastoid muscle narrowing maybe, does that cause both thoracic outlet and cervical instability, AI, posterior injections enough? I don't know what you're talking about there. Sternocleidomastoid muscle part I got. I'm not quite sure what NAURU means. So if you could rephrase that one, that'd be great. Becky, do you know anyone who had high odor throat crunching every time I swallow? Yeah, I mean, it's not uncommon to see patients with anterior injuries. So trauma to the anterior longitudinal ligament, spasm of the longus coli or capitis, or other impacts of the stylohyoid or the strap muscles. So if we look at strap muscles, the strap muscles are all of these muscles in the front. And you've got the hyoid bone up in here. And then you've got all of these small muscles that attach there. Now, just deep to those muscles are the muscles we're talking about. So things like longus coli, longus capitis. So if you get an injury to those deep muscles, that can cause problems in this area. If you have an injury to some of the muscles that attach into the hyoid, you can see the same thing. So yes, we have seen patients with that. Becky, even if someone had alar transverse damage, can they still get better from posterior PRP or stem cells? Is PRP migratory? No, it regrettably doesn't work that way. So if you go to see someone who's doing posterior injections, they're doing those injections into the muscles back in here in the back of the neck. And the muscles we're talking about that are the alar and transverse ligament, those are internal inside the neck. So regrettably, one doesn't have a lot to do with the other. You might get some ligament tightening by working on the muscles or the ligaments in the back, but the central deep ligaments that live between C1 and C2 are going to be in the middle of this picture, internal. So if we look at alar ligament, so we look at alar transverse ligament, those are inside those neck bones, and they serve kind of a different function. So the answer is no, PRP isn't migratory. It's got to be placed exactly where you need it. And there is no way to treat the posterior ligaments, which would be at the bottom of this particular screen, and have that substantially impact the internal ligaments if those internal ligaments are damaged. That's the alar transverse. Hi, I tried Atlas orthogonal. I'm still holding Atlas alignment 5 weeks after adjustment. Should I wait with injections? Yeah, Dan, listen, if you are feeling better for 5 weeks as a result of a single AO adjustment, I think you'd want to try going down that pathway first. So if you are that kind of patient who is going to get better that way, I'd certainly give that a couple months and see where that heads before you consider any kind of injection therapy. Most of our patients who are doing these kind of injections are really focused on, they've been to AO chiropractic. If it helped, it only gives very, very temporary relief. So if you're getting 5 weeks from a single adjustment, congratulations, and that's awesome for you. That's a wonderful place to be. Other questions, guys, I can answer today. Happy to answer anything, whether it's about this topic or another topic. Doesn't really make a difference. And just give everyone a minute or two to get that. In the meantime, I do want to give a follow-up to the last one of these lectures I gave, where the topic was on the concept of spinal cord detethering. I had a patient reach out to me that said, hey, I've got urinary urgency, meaning it feels like I got to pee all the time, and I wake up a lot of times during the night to go pee. Do I have a tethered cord? And the answer is it's theoretically possible, but the likelihood is you do not have a tethered cord. It's much more likely that you've got a common crossover between back pain and urinary urgency or frequency, and that's a well-documented connection. So be very, very careful there. Again, urinary urgency and frequency is common in patients with back pain. So it's possible you have a tethered cord. That's just the 1 in a million connection. Whereas if you've got back pain, it's like a 1 in 4 connection. So just be careful there, because one doesn't generally have anything to do with the other. Stacy, if in imaging C6 is visibly more posteriorly placed than 5 and 7, can regenerative medicine correct that? It should be done for my next PICL. Stacy, I'd have to look at the images. If there's a fixed retrolisthesis, which is what you're describing, meaning that one vertebra is back there and that doesn't change, then it may not be correctable with injections, and it may not be worth doing a fusion. If it moves around as the neck moves, then that's something that can be treated, but would probably just be treated as this at the same time as the PICL, not during a separate treatment. Daniel, sure. Paul, hey, Alex to know, can the cranial bones joints be injected with PRP or stem cells as well? Daniel, or Paul, I'm sorry, we generally don't do that simply because there isn't really any way I can image those things and see exactly where I would need to treat. And in addition, trying to get into those little sutures would be very, very hard to do in an adult. So probably not feasible. Robin, does the size of a synovial cyst at L4 or 5 matter? Does the size of the cyst affect drainage success? No, that's usually not the big thing. Usually people fall into 1 or 2 camps about 6 and 10 times. When you drain it or burst it, it goes away and the person's fine. About 4 and 10 times it needs to be surgically removed. So that's generally how it goes, but the size usually isn't the big operative issue there. Adina, atlantoadenoid osteophytes imply it's too late for PICL PRP. Is the osteophytes imply prior instability and determine the body? Yeah, Adina, so I think number one, it doesn't have to mean that it's too late for PICL, but certainly it does imply that the body is trying to stabilize that area and used bone to do that. and that's not uncommon, especially in older patients. Burke, what is the success rate of Regenexx injections to shoulder people who had HEDS? So treating shoulder pain due to HEDS is pretty common for us, works well. Could be PRP based or could be bone marrow based, depending on what's going on with the shoulder. But generally, that works well. We just need to do a hands-on physical exam and see what's unstable. The AC joint, the glenohumeral joint, etc., and whether or not there's any other damage that's occurred, like rotator cuff, labrum, that kind of stuff. Okay, guys, any other questions I can answer at all? Okay, so we'll start wrapping it up today. I want to thank everyone for watching. I appreciate all your questions. And if I didn't get to your question today, feel free to go ahead and submit those questions, and we'll try to get them answered at a later time. Oh, here's one more question. Phil, I posterior misalignment at C4. I'm not sure what RHS means, plus anterior misalignment. I think you're talking about positional terms, C1, C2, C1, C2 overhang, can tighten ligaments via PRP on its own, resolve subluxation misalignments in the cervical spine. So really what we've been talking about is whether or not that means those things move when you move. So instability is a movement-based concept. So that means that and looking at a DMX or a cervical flexion extension x-ray, if there's motion between those areas, then yes, we can tighten down that via posterior PRP injections. If it's C1, C2, that tends to work less often, and we usually need to directly inject those injections or from the front, and that's that PICL procedure. So I need to know more about what's happening when you move, because that's how instability is defined. Okay, guys, thanks so much for watching. Have a great day. I will be available to do this coming Friday as well. We're going to pick a topic for that. And same thing there. We'll be on all 3 channels, my YouTube channel, Facebook Live on Centeno Schultz, Facebook Live on Regenexx. And you can ask any question you want or ask about the topic, whichever is fine with me. So thanks so much for watching, and have a great day.